Hi class, welcome to Unit 5. This has, I believe, 4 chapters that we need to discuss. Disregard the Part 1 label on this slide. We will do all 4 chapters sequentially. There is no Part 2. So the first chapter is Chapter 25, and this is anti-inflammatory drugs. And these are drugs that we are given very, very commonly. Um, so the first thing we need to talk about is what is inflammation. Inflammation is the response to tissue injury and or infection. When the inflammatory process occurs, a vascular reaction takes place in which fluid, elements of blood, leukocytes, which are white blood cells, and chemical mediators, they accumulate at the injured tissue or infection site. The chemical mediators are histamine, kinins, and prostaglandins. There are some cardinal signs of inflammation, and you should know these. They are redness, swelling, heat, pain, and loss of function. Redness occurs in the first phase of inflammation. What happens is blood accumulates in the area of tissue injury because of the body's release of chemical mediators. Those are those kinins, prostaglandins, and histamine. Next is edema. Edema is swelling, and that's the second stage of inflammation. What happens there is plasma leaks into the interstitial tissue at the injury site. Heat at the inflammatory site can be caused by an increase in blood accumulation and can also result from pyrogens. Those are the substances that produce fever, and those interfere with temperature regulation in the hypothalamus. The pain is caused by tissue swelling and the release of the chemical mediators. Loss of function happens because of the accumulation of fluid in the tissue injury site, and because of pain too, because that decreases the mobility of the affected site. So prostaglandins is a key term to be familiar with, and what they do is they cause vasodilatation, smooth muscle relaxation. They also increase capillary permeability, and they increase nerve sensitivity to pain. Anti-inflammatories act to relieve pain, decrease elevated body temperatures, and inhibit platelet aggregation. So this slide talks a little bit more about the individual roles of histamines, prostaglandins, and then our COX enzymes. Cyclooxygenase, which does not roll off the tongue. And then we have some anti-inflammatory drug groups that you need to be familiar with, and we're going to talk about these more in depth. They are non-steroidal anti-inflammatory drugs, also called NSAIDs. We are also going to talk about corticosteroids, disease-modifying anti-rheumatic drugs, and anti-gout drugs. And an important thing on this slide to note is that those COX enzymes, there are COX-1 and COX-2. So depending on which enzyme we're talking about, COX-1 serves to protect the stomach lining and regulates blood platelets. COX-2 triggers inflammation and pain. And when we talk about non-steroidal anti-inflammatory drugs, they can inhibit both or one of those COX enzymes. So let's first talk about NSAIDs. NSAIDs, and we kind of throw aspirin into this category, even though technically it's not really an NSAID. It's a solidusate. Um, so basically, NSAIDs and aspirins are drugs that work to inhibit the COX enzyme, which is needed for the biosynthesis of prostaglandins. Like I said, some of them affect both 1 and 2, some of them affect just one and not the other. NSAIDs are typically inexpensive and can be purchased over the counter. Some examples are aspirin, ibuprofen, naproxen. Um, People with rheumatoid arthritis and osteoarthritis are ones that respond very well to the NSAID group. NSAIDs reduce pain and decrease inflammation, but it can take time before the patient will notice any improvement. So it's not like it works immediately for every case. We will be going over aspirin and NSAIDs. Aspirin is technically an anti-inflammatory as well as a low-level anticoagulant. And because the aspirin is an anticoagulant, we want to be careful with it because it increases the risk of bleeding, especially if the patient is already taking another anticoagulant. And it's very important to remember that with aspirin, we don't give it to children, especially if they've had a recent flu or viral infection, because it can cause Reyes syndrome, which is REYE''S. And Reyes syndrome can be potentially life-threatening. It involves swelling of the liver and the brain. So Tylenol, acetaminophen, is the safest choice for any child for an over-the-counter pain medication. So let's first talk about aspirin. It helps with pain. We also use it if someone is having a heart attack or a stroke. It specifically inhibits COX-2. We don't take it with other NSAIDs because it decreases its effectiveness. Aspirin has been known to cause GI upset. It's very notorious for that. If that occurs, we want to talk to the physician about changing it to an enteric-coated aspirin. There are some interactions we need to be aware of with aspirin. Drugs, it will increase the bleeding time with anticoagulants. Hypoglycemia is possible if taken with oral antidiabetics. And there's an increased risk for gastric ulcers when taken with glucocorticoids. For lab values, taking aspirin, and we draw your lab values, these are the following effects you can see. You can see an increase in your PT, prothrombin time, your INR, your bleeding time, and your uric acid level. It can cause decreases in your potassium, your cholesterol, and your T3 and T4, your thyroid levels. There are also foods that contain salicylates. For example, prunes, raisins, licorice, and some spices. And so aspirin, if taken too much, can have some problems. So let's talk about those. We want to be cautious when we are taking them in conjunction with other medications. We want to avoid these drugs, specifically aspirin, during the third trimester of pregnancy. We never get it to kids, especially kids with flu or viral symptoms. Side effects / adverse effects. You can see a hypersensitivity, and that usually is associated with tinnitus, which is ringing in the ears, dizziness. You can also have bronchospasms. That's more common in people that have asthma that take aspirin. You can have mild side effects, tinnitus, dizziness, headache, confusion, sweating, drowsiness, thirst, nausea, vomiting, diarrhea. Then you can have symptoms of toxicity, convulsions, or if it is really bad, cardiovascular collapse or coma. So aspirin is not harmless, but if we take it in the recommended doses, the recommended frequency, for the recommended duration, it is safe to take. But we do want to be cautious and provide good patient education. Okay, so let's jump ahead to our next drug. Uh, this is Voltaren diclofenac. It is a topical or oral medication. Voltaren is a pain reliever that works on inflammation as well. Common reasons to take Voltaren are if you have rheumatoid arthritis, osteoarthritis. There is no antipyretic, so it isn't going to reduce a fever. Then another common one you should be familiar with is Toradol. That one works by inhibiting prostaglandin synthesis. And your diflunac, that one is a COX inhibitor. Back to Toradol, it's recommended specifically for short-term management of pain. It's injectable. It's great for moderate to severe pain, and it's as effective or better than an opioid for pain. From there, let's talk ibuprofen. The trade names are Motrin or Advil. It has similar effects to aspirin, but ibuprofen is less irritating to the stomach and more effective. You can look to table 25-2 in this chapter, which compares those different anti-inflammatory nonsteroidal agents. There's also a prototype drug chart, 25-2 for ibuprofen. And so interactions, increased bleeding with warfarin, increased effects with phenytoin, sulfonamides, which are antibiotics. It decreased effect with aspirin. So we don't take ibuprofen and aspirin together because they're both going to be lower effectiveness. There are some common side effects. Gastric distress, and we can prevent that by taking it with food. You can also have symptoms if you have too much of it, like tinnitus, dizziness, confusion, edema. You can even see with higher levels blood dyscrasias, heart dysrhythmias, and these can be ibuprofen, Advil, Motrin can be nephrotoxic. So it's primarily excreted by the kidneys. If you take too much of it, it can damage your kidneys. And then another propionic, I have a heck of a time saying this word too. Propionic acid derivative is naproxen. That one is great for pain relief as well. It does not have the bleeding risks though. So that brings us to selective COX-2 inhibitors. So these work only on COX-2, not COX-1. What do? They decrease inflammation and pain. Celebrex is a common drug of this classification. Again, we want to avoid it in the third trimester of pregnancy. It has some side effects. You can still have that GI distress. You can also have headache, dizziness, sinusitis, and some peripheral edema. And just as a side note, before we move on to corticosteroids, NSAID use in older adults. As nurses, we need to know that there's a greater incidence of GI distress and ulcerations associated with NSAIDs in older adults. And a lot of times we need a reduced dose to decrease the risk of side effects in older adults. So that brings us to corticosteroids. And some examples are prednisone, prednisolone, dexamethasone. So they all end in that ONE. And how they help is they control inflammation by suppressing or preventing the inflammatory process. It's not a great drug of choice for those osteoarthritis or rheumatoid arthritis because these have a lot of side effects. They are frequently used to control acute flare-ups. So we'll give them a dose for a few days and then we'll taper it off. This shouldn't be used chronically. And let's talk specifically about anti-rheumatic drugs. So cytoxan, Methotrexate, these are some common ones. They basically suppress the immune system. That's why they're immunosuppressant agents. And then because we suppress the immune system, it also in turn suppress the inflammatory process. These can be used to manage rheumatoid arthritis when other treatments fail. There are also something called immunomodulators. Those are your more expensive, newer drugs like Remicade, Humira. With Remicade, we want to be sure to monitor the complete blood cell count. Um, and basically, they disrupt the inflammatory process using tumor necrosis factor. Um, so, a very advanced technology was developed when we use these medications. And these are commonly used for rheumatoid arthritis. So let's talk for a minute about arthritis. So this picture shows you a normal joint, an osteoarthritic joint, and a rheumatoid arthritis joint. So with the osteoarthritis, there's a thinning of the cartilage and then the bones rub together, which causes pain. With rheumatoid, you have swollen and inflamed synovial membranes, which causes pain and some bone erosion. So usually with any arthritis diagnosis, they're going to start with NSAIDs like ibuprofen. Then they progress to more potent drugs for those people who are showing signs of joint damage. We know today that an aggressive approach is more effective and will result in fewer symptoms, better function, less joint damage, and decreased disability. The goal for treatment is to put the disease in remission. One medication that's advanced and very expensive is Remicade, which I talked about, and we need to watch those blood cell counts with Remicade. They can also make it easier for you to bleed and make it easier for you to get sick because of how it affects the inflammatory process and the immune system. Okay, so that brings us to anti-malarial drugs. These can be used off-label to treat rheumatoid arthritis when other methods fail. We don't really know why they help. We just know that they do help, but it takes time. It takes 4 to 12 weeks for the effect to be really seen. And anti-malarials are typically used in combination with NSAIDs to help keep arthritis under control. So moving from arthritis to gout, what is gout? It's an inflammatory disease. It can be of the joints, the tendons, or other tissues. A lot of times it starts and it flares up in the great toe. And basically what's happening is there a defect in the body's purine metabolism. And I've got on this slide some examples of foods that contain purine. And this defect leads to uric acid levels to be elevated. And so what we treat it with is a lot of times colchicine. It's a very commonly prescribed anti-gout. And it has some common side effects, GI distress, so we advise to take it with food. But people shouldn't take colchicine if they've got severe kidney, heart, or gastrointestinal problems. And with anti-gout medications, you always want to encourage increased fluid intake unless it's counterindicated by other health conditions. So along with colchicine, there is allopurinol. So basically you want to get to a point where you think colchicine and allopurinol. Oh, does the patient have gout? So you can also refer to table 25-4, which has anti-gout drugs listed in this chapter. So allopurinol is different because it decreases the production of uric acid, and it can be used prophylactically to prevent gout attacks. And then there's some specific nursing interventions. So we want these patients to increase their fluid intake unless it's contraindicated by another health condition. We're going to monitor their CBC, They're liver enzymes, and remember, those are your ALT and AST. Okay, and then we also, sorry about the barking there, we also want to monitor renal function tests, and that's your BUN and creatinine. We're going to tell these patients to get yearly eye examinations to assess for any changes in the eyes. And we want these people to avoid alcohol, caffeine, and thiazide diuretics because all of these can increase uric acid levels. Okay, then just to touch on another classification of anti-gout medications is probenecid. This one works by increasing the excretion of uric acid, and it blocks the reabsorption of it. It does have that gastric irritation as a side effect, so again, take it with food. This one is highly protein binding, so you want to be careful when you give it with other highly protein binding drugs. And as I've mentioned a couple of times, we want to increase that fluid intake because that helps get rid of the uric acid through excretion. Okay, that brings us to the end of the anti-inflammatory drugs. Please let me know if you have any questions, and we're going to move forward to our non-opioid and opioid analgesics. And analgesics just mean they relieve pain. So treatment of pain is a major issue in healthcare today. Pain is a complex issue, and if we undertreat pain, it can have a lot of harmful effects involving the whole body. In addition to psychological and physical suffering, inadequate pain management leads to high healthcare costs. And there are some reasons why we might undertreat pain. It could be the patient's willingness to acknowledge how much pain they're in. It could be the patient's inability to describe their pain. It could be the nurse's inability to measure the pain, a lack of regular pain assessments. It could be the attitude of the healthcare team. It could be an unwillingness to believe the patient's report of pain. And very commonly, it could be an inaccurate knowledge of the healthcare provider concerning addiction and tolerance and how to prescribe an adequate analgesic dose. So speaking of inadequate analgesic dose, what drug is appropriate for what type of pain? So non-opioid analgesics are less potent than opioids. Non-opioids are used to treat mild to moderate pain. Opioids are for moderate to severe pain. Just as a side note, patients with a history of substance abuse still require pain medication and a thorough pain assessment. And the nurse, you need to know that opioids are safe and effective in this period, but they may require larger doses and more frequency than your patients that do not have a substance abuse history. We know this to be true, and we need to dose them appropriately. So, what is pain? Pain is the fifth vital sign. It is a personal experience. We can't tell if a patient how severe their pain is. There are some nonverbal body signs that we can watch for in, say, infants, nonverbal children, people that have communication issues. But if your patient can talk to you, doing a good pain assessment is critically important. So the PQRST should be your go-to routine for assessing pain. So, okay. Do you have any pain? Can you rate that pain on a 0 to 10 scale, where 0 is no pain, 10 is the worst pain you've ever experienced? Can you tell me how the pain feels? Can you describe the pain? Is it sharp? Is it dull? Is it aching? Is it throbbing? Is it stabbing? Is it burning? Um, where is it at? You say it's your back. What part of your back is it? These are just examples of the questions that nurses have to ask in order to get a good quality pain assessment. And then there's some terminology here. Pain threshold. Pain threshold is individualized to each unique patient, and it reflects the level of stimulus needed to create a painful sensation. What might hurt me may feel like just a nuisance to you. So it has to be based on the patient's report. Next, there's pain tolerance, and that is the amount of pain one can endure without having it interfere with normal functioning. Um, and then our analgesics, those are our pain medication. And pain meds are tricky. They can be good with helping with pain, but they have their problems as well. If we give too much of a pain medication, you can cause respiratory depression, so a respiratory rate less than 10. Um, we are taught not to doubt someone when they say they are in pain because everyone perceives pain differently. There are some classic signs of pain, though, that we can assess. And this is when I was talking about those nonverbals. High blood pressure. With acute pain, we see a spike in blood pressure and we see an increase in heart rate as well with acute pain. You can also see changes in facial expressions such as grimacing. You could see people cradling the site that hurts or trying to protect the site that hurts. You can see things like restlessness. You can see withdrawal from the stimuli. These are all things that we can monitor in patients that are not able to speak for themselves. And with pain medication, just in general, I've already told you that people that have a history of substance abuse are going to need higher doses and higher frequencies. People with cancer, they're going to need a much higher dose of opioid analgesics because of how severe their pain can become with cancer. And so the physician will titrate their medications. So that means raise them, lower them until we get good pain control with few or tolerable side effects. Just a side note that it's important to know, if you do have a patient that has a history of abusing opioids, expect the doctor to order buprenorphine because it is a great pain medication, but it doesn't have such a high risk for abuse potential. So I talked a little bit about, okay, what type of medicine is important for what type of pain. So the WHO has developed this pain ladder, and there's 3 steps to this ladder. Step 1 is if your patient reports mild pain. So we use the 0 to 10 pain scale. Basically, you can do it like 1 to 4 is mild pain, 5 to 6 or 5 to 7 is moderate, 8 to 10 is severe. I'm just ballparking it to give you an idea of how the breakdown is. So if your patient reports mild pain, what are appropriate drugs? We can use aspirin. We can use acetaminophen, which is Tylenol. We can use some NSAIDs like ibuprofen, naproxen. Now, what if they're reporting moderate pain? Then these are the drugs that are appropriate. We could try acetaminophen or aspirin. We could try codeine, hydrocodone, oxycodone, tramadol, and the aspirin and acetaminophen with the plus behind it, that means paired. So acetaminophen paired with codeine, acetaminophen paired with oxycodone, acetaminophen paired with hydrocodone. So that's a pairing. That's moderate pain. And then once you get to a patient that is reporting severe pain, that's when we're going to go to the big guns. And usually if it's severe pain, we're going to try IV because if someone's in severe pain, we want their relief to be fast. So that's when we're going to, or we could also do IM injections. We're going to use drugs like morphine, hydromorphone, methadone, fentanyl, oxycodone. And then you can add in non-opioid analgesics to help with breakthrough pain. So when we figure out the best way to start, we should use an objective tool such as this pain ladder based on what our pain report is from the patient and what the diagnosis is for what is causing the pain. So this is just a touch base on those non-opioids that we talked about in the anti-inflammatory chapter. So that's aspirin, acetaminophen, ibuprofen, which you could also know as Advil or Motrin. You can use naproxen, which you may know as Aleve. These are less potent than opioids. They have analgesic, antipyretic, and anti-inflammatory effects. They're used to treat mild to moderate pain. They are effective for dull, throbbing pain of headaches, pain associated with dysmenorrhea, inflammation, minor abrasions, muscle aches and pains, mild to moderate arthritis. Just a few reminders with aspirin. Watch for stomach pain, which can progress to a GI bleed, tinnitus, and thrombocytopenia. Thrombocytopenia is low platelet counts. So, and remember, we don't give aspirin to children because of the risk of Reye's syndrome. Signs and symptoms of Reye's are persistent or continuous vomiting. Then there's the signs of brain dysfunction, listlessness, loss of pep of energy, and drowsiness. So from aspirin, let's touch base on acetaminophen. It's not technically an NSAID. It does inhibit prostaglandin synthesis. It's helpful for pain, discomfort, and fever. There's a maximum amount of acetaminophen that can be taken in 24 hours. For a healthy adult, that maximum dose is 4 grams or 4,000 milligrams. Now, for elderly patients, it is 3 grams per day, and there are rumors that guidelines are going to be changing to 3 grams per day for everybody, but that hasn't come down the pipeline yet. And it's important to remember that taking too much Tylenol can damage your liver. So if a patient tells you they take a lot of Tylenol on a regular basis, we should anticipate the physician ordering liver function tests. So remember, our liver function tests are our ALT and AST. As for the risk of thrombocytopenia, we're going to watch for signs and symptoms of unexpected bleeding. So that can be unexpected bruising, petechiae, bleeding from the gums when they brush their teeth, a pink tinge to their urine. All those are signs of bleeding. And remember that acetaminophen has an antidote. It is acetylcysteine, and the short name for it is Mucomyst, which I'll spell, MYCOMYST. And remember, acetaminophen is the best choice for pain reliever, fever reducers in children because we don't have that Reye's syndrome risk. So now let's switch gears over to opioid analgesics. These are indicated for moderate to severe pain. They act mostly on the central nervous system. They not only suppress pain impulses, but they also suppress respiration and coughing because they work on the respiratory and cough centers of the brainstem. They also can relieve the cough. So we call them antitussives. That means it reduces the cough impulse. And the other thing is it can slow other things down, such as the digestive system, so it can cause constipation. Let's see. Side effects. What we're worried about is respiratory depression. Excuse me. And then constipation. You can also have nausea and vomiting. You can see a little bit of a lowering of their blood pressure. These people are at risk for orthostatic hypotension. And with high doses, you can also see some urinary retention. That's a little bit more common in older adults. So an example of an opioid is morphine. Morphine is an extract from opium, and it is a potent opioid analgesic. Morphine is most effective against acute pain. And some examples of when we commonly use it is heart attacks, cancer. We will use it for shortness of breath associated with pulmonary edema. It can cause those problems, though, that we talked about: respiratory depression, orthostatic hypotension, urinary retention, constipation, and cough suppressant. A common side effect of morphine is pruritus. So remember, pruritus is itching. And so if a patient is given a dose of morphine and they complain of feeling itchy, if it's not an allergic reaction, their vital signs will be within normal limits. If it is an allergic reaction, their vital signs are not going to be normal. And so the other thing to know is an antidote for opioid overdose is naloxone, otherwise called Narcan. Let's see. Chronic use of opioids can develop to tolerance, and you can then need higher doses to achieve pain control once you have a level of tolerance. And that's not addiction, that's tolerance. If someone takes opioids on a daily basis and then it's abruptly stopped, these people will have withdrawal symptoms that typically occur within 24 to 48 hours after the last dose. And just as a caution, we want to avoid using opioids for any patient that has a head injury because of the respiratory depression that can occur. And so when your respiratory rate is depressed, you're going to have more carbon dioxide. More carbon dioxide causes blood vessels to dilate, especially in the brain, and that can trigger intracranial pressure. So a lot of information about opioids. We use them a lot, but you really have to be careful and do good assessments of your patient. Another time we maybe don't want to use an opioid if a patient has a low blood pressure, because again, it's going to lower their blood pressure more. And remember that opioids are oftentimes paired with an NSAID, for example, acetaminophen, and they complement each other, so you get better results. Another opioid to touch base on is Demerol. This is one of the first synthetic opioids that were created in a lab. During pregnancy, this drug is preferred to morphine because it doesn't decrease uterine contractions and it causes less neonatal respiratory depression. But this drug is not indicated for patients with chronic pain, severe liver dysfunction, people with a history of seizures, or severe coronary artery disease. And we want to be cautious when giving these to older adults. Next one, this is another opioid. This is more powerful than morphine. It's similar to morphine, but it's more potent by approximately 6 times. And this is Dilaudid hydromorphone. This is a semi-synthetic opioid. And it actually has fewer hypnotic effects and less GI distress. Many of the side effects are those that are common to opioids. Like I mentioned numerous times before, that respiratory depression, orthostatic hypotension, drowsiness, constipation, urinary retention. And then let's just touch base on analgesic use in special populations. And I've talked a little bit about tolerance. I'd like to touch base on addiction. What addiction is a psychological and physical dependence on a substance beyond normal voluntary control. It usually occurs after prolonged use of a substance. So, what typically happens is someone is prescribed an opioid for a genuine medical condition, but they take it for too long. The problem gets resolved, but they are psychologically and physically dependent and want to maintain use of that drug. Um, Pain management in children is a complex special population to consider because it's more difficult to assess their pain. So, nurses have to be sure to use age appropriate communication skills. But a child, like an adult, should always be given pain medication before pain becomes severe. We don't assume just because they're children and they don't tell you it hurts that they have no pain. So then we get to older adults. So typically those are adults that are 65 or older. They require drug adjustment doses to avoid severe side effects. Because in older adults, the side effects using opioids are more pronounced. So we have to watch this patient population very closely for adverse reactions. And older adults tend to have different beliefs and fears than younger generations regarding opioids. And sometimes we have to do some patient education that it's okay to take these medications. And, getting good pain control is going to get them back on their feet faster. And then with cognitive impairment or sensory perceptual impairment, you need to rely on a more thorough physical assessment to discover the presence of pain because self-reports may not be reliable. And remember, those people that have a history of substance abuse, we want to turn to that particular medication. Can anybody remember what that is? Buprenorphine, because it has a reduced risk of addiction with it. Then let's talk on adjuvant therapies. Those are treatment modalities that are usually used along with either a non-opioid or an opioid. Some specific examples are anticonvulsants, antidepressants, corticosteroids, antidysrhythmics, and local anesthetics. So the way that anticonvulsants help is they prevent the production of nerve impulses by stabilizing the membrane and inactivating the sodium channels. They work on peripheral nerves and the central nervous system. They can be used very effectively for neuropathic pain and for the prevention of migraine headaches. Antidepressants, tricyclic antidepressants, they prevent the reuptake of serotonin and norepinephrine, and lower doses of tricyclics are usually prescribed for treating peripheral neuropathy. Corticosteroids can work by reducing stimuli. Antidysrhythmics can work by blocking sodium channels to reduce pain. And then local anesthetics can be effective by interrupting the transmission of pain signals to the brain. So a variety of different options. Okay, so that brings us to opioid agonist antagonists. Buprenorphine, that's the drug that I've mentioned a couple of times. That's the one that's good when people have a history of opioid abuse. So this class of drugs are not given for cancer pain because there's a risk of central nervous system toxicity from the high doses that are needed. These are considered to be safe for use during labor, but they haven't been established as being safe in pregnancy. Nubane is probably the one that I've seen used most commonly for pain management. Okay, then we've got opioid antagonists. which you should see the first one listed there as familiar because I've mentioned it. That's the reversal agent for opioid overdose. That's Narcan, naloxone. We use that to reverse respiratory depression, sedation, etc. These are the antidotes for overdoses of any opioid. And just a few words further on Narcan because it's so important for you to know this drug. It can be given IM or IV, and they are going to reverse that respiratory depression, but they do have some side effects. So you could see rebound, hypertension, tachycardia, nausea, vomiting. But the good thing is your patient will be breathing again. Okay, and that brings us to the end of chapter 26. And our next topic is chapter 27, Antipsychotics and Anxiolytics. Those are for anxiety. So let's first talk about psychosis. What is psychosis? That's when someone loses contact with reality. It can be manifested in a variety of mental or psychiatric disorders. It's usually characterized by having more than one of these symptoms. Difficulty in processing information and coming to a conclusion. They can have delusions, hallucinations. They could be incoherent. They can have catatonia or aggressive or violent behavior. All of those are symptoms of psychosis. Then we get into schizophrenia. Schizophrenia is a chronic psychotic disorder that usually presents in adolescence or early adulthood. And we say they have positive and negative symptoms, and they're listed here. And then the little picture on the side gives you some more specific examples of signs of schizophrenia. So how are we going to treat it? We're going to use antipsychotic agents. The big action is they block dopamine. When dopamine is blocked, it can have some side effects, and we're going to spend some time on a future slide talking about that. But there are two major categories of antipsychotics you want to focus in on. So the first one is typical, the second one is atypical. So typical, they can sometimes be called traditional. And a common example of that is Haldol, and we're going to talk about Haldol more. And then for atypical, those are a lot of times like second generation or more recently discovered. And there's more of those that are commonly used. Some big ones are Zyprexa, Risperidol, Seroquel, Clozaril, and a very recent one is Latuda. And we're going to talk about select ones of those. So typical. The two typical ones that I really want to focus in on are Haldol and Cogentin. The big things for you to know about Haldol is anybody who's on it, look it up and look for interactions because it has a ton of interactions and side effects. The ones we want to really watch out for are the extrapyramidal side effects, which I'm going to have another slide where I talk about what that is. Anticholinergic side effects, which you should remember because we've talked about cholinergic drugs before. Then we can also have tardive dyskinesia or dystonias, and I'm going to talk about those on a separate slide too. The other typical or first generation antipsychotic is Cogentin, and that one is used frequently to decrease extrapyramidal side effects, so patients can take an older medication. So they're taking an older medication, they've got some EPS side effects, we're going to give them Cogentin to help manage those side effects. But let's talk about what the key atypical antipsychotics you need to be familiar with. So these ones also block dopamine receptors, but to a lesser degree than your typical antipsychotics. And atypicals also block serotonin too. So the two big ones that I want you to focus in on for this slide is clozapine and Zyprexa. Clozapine has fewer side effects, but it can cause weight gain, drowsiness, and headaches. It's often used instead of typical antipsychotics like Haldol because it has fewer side effects. With clozapine, like the little picture shows you, we want to look for agranulocytosis, and that's a lowered white blood cell count. We want to watch for intermittent tachycardia and seizures. And so a nursing intervention is to monitor weekly white blood cell counts. And Zyprexa has a bonus because it doesn't cause EPS and it doesn't cause agranulocytosis, so we don't have to do those CBCs. Okay, next atypical one for you to focus in on is risperidone. This one has some common side effects you should know. That's sedation, headaches, and photosensitivity. It can also cause some anticholinergic side effects like dry mouth, urinary retention, and we want to be careful when taking these with an antihypertensive medication. From there, let's talk a little bit about phenothiazines, specifically thorazine, proloxin. Those are probably the big ones for you to focus in on. And thorazine is useful, but it has strong sedation side effects, severe orthostatic hypotension. Proloxin, that is good for managing schizophrenia. It does have some side effects. You'll see the anticholinergic ones again, so dry mouth, nasal congestion, photosensitivity, urinary retention, that sort of thing. And then let's look ahead to the next slide. Haldol, we're circling back to that one. That's that typical antipsychotic that you want to be familiar with. And it blocks dopamine. It treats not just schizophrenia, but it also treats acute and chronic psychosis, and it can help with dementia. Some reasons not to give it: narrow angle glaucoma, if your patient is already sedated, or if they have severe liver, kidney, or cardiovascular disease. So I've got a picture for Haldol with some key stuff for you to know. So what are we going to watch for? We're going to watch for extrapyramidal reactions, tardive dyskinesia, akathisia, acute dystonia, and then your anticholinergic, constipation, blurred vision, dry mouth. Side effects, we've touched on that. Some interactions, there's an increase toxicity if we give it with other anticholinergics. Increased sedation if we give it with alcohol, so your patient should not drink while they're taking this, or other central nervous system depressions. So, for example, we just talked about opioids, and opioids depress the respiratory and central nervous system. So we would want to be cautious with giving anything like that to a patient that's already taking Haldol. And so from here, I want to talk about some of those severe side effects that we need to watch for specifically in these patients that take an antipsychotic. So EPS, they look like Parkinson's symptoms. So you can have a tremor, mask-like face. You can have rigidity, a shuffling gait. And that can actually develop further into something called an acute dystonia. And acute dystonia can develop muscle spasms of the face, tongue, neck, and back. You can see facial grimacing, involuntary eyeward motions looking upwards, laryngeal spasms. You can have akathisia, which is constant motion, like they can't sit still, that's pacing. And then tardive dyskinesia, which is something that you'll see if you spend any time on a psych unit. That's a protrusion and rolling of the tongue and a chewing action. And they don't know they're doing it and they can't stop doing it. So those are the big things. And then I've got another slide here that shows you these with a picture to show you what they're talking about. So we've got those pseudoparkinsonism symptoms. We've got the acute dystonia, the akinesia, tardive dyskinesia. These are important side effects of these medications that you need to be familiar with. And then a rare, potentially fatal syndrome that you need to know about is neuroleptic malignant syndrome. So what are the symptoms? Altered mental status or seizures. They can experience muscle rigidity or a sudden high fever. Their blood pressure can go up and down. They can develop heart dysrhythmias or tachycardia. They can show or complain of the symptoms of rhabdomyolysis. And I know after the Unit 4 discussion board question, everybody knows what rhabdo is. And rhabdomyolysis can lead to acute renal failure. People can also have respiratory failure or coma. And what do we do about this if we see these symptoms? Immediate withdrawal of antipsychotics and then supportive care. Hydration, hypothermic or cooling blankets. We're going to give them antipyretics to lower that fever. We're going to use benzodiazepines and muscle relaxants. Okay, so I want to end our antipsychotic discussion by talking about what are some nursing interventions that we have to do for any patient on any antipsychotic. So we're going to monitor their vital signs. We're going to assess patients for cheeking their medications. So that means instead of swallowing it, they kind of tuck it into their cheek. We're going to give these meds with food or milk to decrease the risk of stomach upset. We're going to monitor for those side effects. We're going to monitor white blood cells because remember, these can lower white blood cells. They may have some changes in their urine color. We have to educate these patients that it can take weeks, specifically 3 to 6 weeks, to achieve effectiveness. We want to encourage these patients not to smoke. We don't want them to combine these drugs with alcohol, narcotics, or other central nervous system depressants. And we don't want these patients to suddenly stop these meds because it can cause a sudden reoccurrence of psychotic symptoms. All right, that brings us to the end of psychosis. Okay, moving ahead, let's talk about anxiety. Anxiety is not caused by a medical condition or drug use if it's primary. If it is secondary, it's related to an underlying condition or medication. If it's primary, we usually treat it with anxiolytics. If it's secondary, we usually don't treat it, or we treat it just based on the patient's severity. There are some treatment options. Most commonly, we're going to turn to benzodiazepine medications. And I've listed some of the most common ones on this slide. So Valium, Ativan, Xanax, those are probably ones that you've seen. So let's talk Ativan. Ativan inhibits GABA neurotransmitters, and it works as an anti-anxiety medication, an anti-seizure medication, and it helps preoperatively. It does have some side effects. So we've got drowsiness, dizziness, confusion, weakness, restlessness. It can even cause some GI disturbances. It does have some interactions. We want to be careful with other medications that depress the central nervous system. For example, opioids or alcohol. We want to be careful when your patient is on phenytoin or levodopa. Smoking decreases its effectiveness. and an herbal remedy, kava kava, can actually make it worse or stronger. Um, Withdrawal can occur. It develops slowly in 2 to 10 days, and it can last several weeks. And there are some of the symptoms of withdrawal listed there. What are the key nursing interventions for anybody who's on an anti-anxiety agent? Well, we want to monitor their vital signs. We want to encourage them to change positions slowly to avoid orthostatic hypotension. We want to warn them that it could take 1 to 2 weeks to get a consistent therapeutic response to this medication. And until they know how this drug affects them, they should not drive a motor vehicle or operate dangerous equipment. Patients should not use this for more than 3 to 4 months because tolerance develops and they become less effective with prolonged use. We don't want them to take any antacids or caffeine at the same time. I already talked about the kava kava. They can take it with meals or shortly after a meal to decrease any GI discomfort. And we don't want these people to stop it abruptly because, like I said, they can kind of get used to it when in 2 to 10 days, and then stopping it abruptly can cause the symptoms to come back worse versus a tapering, which allows the body to adjust to no longer using the anti-anxiety medication. And then there's just one other anti-anxiety medication I want to touch base on, and that's Buspar. Buspar is an anti-anxiety medication, but it's different because it binds to both serotonin and dopamine, and it takes 1 to 2 weeks for it to become effective. It does have fewer side effects, which is a bonus. So it has less sedation, less physical and psychological dependency than benzodiazepines, and an interaction with grapefruit juice that we need to avoid. Common side effects, a little bit of drowsiness, some dizziness, headache, that sort of thing. But usually it's much less than what you find with the benzodiazepines. Okay, that brings us to chapter 28, and this is probably the biggest chapter out of this unit. All right, so let's talk about depression. Depression is a mood disorder, and it involves the following signs and symptoms. And the basic pathology behind it, pathophysiology behind it, is there's just not enough of those critical neurotransmitters available. There is a genetic predisposition to developing depression, and there are also some social and environmental factors. There are different types of depression. There's reactive, which is caused by a precipitating event, for example, the death of a loved one. There's major depression, and then there's bipolar. So that's when you swing between a manic phase and a depressive phase. There are some herbal supplements, and we talked about these in Unit 3, but these have been, there's been research studies performed on these herbal remedies, and the results have not indicated that they really work very well for managing depression. But all that being said, some people do still take these, and there are some precautions that should be related with them. And remember that from Unit 3, St. John's wort does cause some photosensitivity, and we need to educate the patient about that. Then there's the classes of drugs that we are prescribed for depression, major depression. So those are your tricyclic antidepressants, your selective serotonin reuptake inhibitors. We call those SSRIs. Next is the serotonin norepinephrine reuptake inhibitors. We call those SNRIs. Then you've got atypical antidepressants, and then the last one that just is not prescribed very often anymore are your monoamine oxidase inhibitors, or MAOIs. So let's talk tricyclics first. So a common tricyclic antidepressant is amitriptyline or nortriptyline. Those block the reuptake of neurotransmitters norepinephrine and serotonin, but it also blocks histamine. And so it works to elevate the mood, increase interest in activities of daily life, and decrease insomnia. Um, the big one I'm going to focus in on is amitriptyline. It does have some interactions, so that alcohol and central nervous system depressants. You're going to see increased sedation and anticholinergic side effects if given with phenothiazine like haldol. Tricyclic antidepressants do have some side effects: sedation, dizziness, blurred vision, dry mouth, constipation, urinary retention. And some of those, if you remember, those are those anticholinergic side effects. You can also develop orthostatic hypotension, and on the more adverse side of a reaction, dysrhythmias, extrapyramidal symptoms, and blood dyscrasias. So these ones aren't usually frontline treatment either. SSRIs are a frontline commonly prescribed. They're popular because they don't cause sedation, they don't cause hypotension, they don't have those anticholinergic side effects or the cardiotoxicity like the tricyclics can. So what do? They selectively block the reuptake of serotonin. And when I say block the uptake, so these serotonin neurotransmitters are floating around in the brain between the brain cells. And if we take one up, we're taking it up and we're using it and we hold on to it. So if we block that uptake, that means that can't be used up and held on to, which makes more of it being free and floating around. And so selective serotonin reuptake inhibitors have some common side effects: stomach upset, sexual dysfunction, and the risk for serotonin syndrome. So the common ones that we see prescribed frequently are your Prozac, your Zoloft, Paxil, and Lexapro. And they can be used for major depression. They also can be used for some anxiety disorders, and they can also be used to prevent migraine headaches. Interactions, you should be able to predict it by this point. Increase central nervous system effects if mixed with alcohol or other CNS depressants. Common side effects: headache, nervousness, restlessness, insomnia. That can be a big one. So generally, we want to educate these patients to take their SSRI early in the day to avoid interrupting sleep. And so these side effects can happen when they first start taking it, but they usually decrease over 2 to 4 weeks of use. So they do go away or subside. That brings us to the SNRIs. So these ones block the reuptake of serotonin and norepinephrine. And some common particular medications are Effexor and Cymbalta. So these are used for major depression as well as anxiety disorders. There's a key interaction between Effexor and St. John's wort. And really, a good rule of thumb is to discourage any antidepressant taking with St. John's wort, because it does just increase the risk of serotonin syndromes, neuroleptic malignant syndrome. It's just not a good idea. So what are the side effects? Well, let's talk about Effexor. Side effects: dizziness, drowsiness, insomnia, headache, photosensitivity. Adverse effects: low sodium, bleeding problems, hypertension, angioedema, which, if you remember, we talked about what angioedema is in relation to ACE inhibitors. And we can also see increase in suicidal ideation, and it can even cause Stevens-Johnson syndrome. And Stevens-Johnson syndrome has the following signs and symptoms: You're not going to be tested on this, but just so that you know what it is. Um, you can have a fever. You can have an unexplained widespread skin rash. You can have pain, blisters on your skin and your mucous membranes of your mouth, nose, eyes, and even genitals. And then your skin sheds within days after those blisters are formed. And then before you get the rash, you could have fever, fatigue, cough, burning eyes. And Steven Johnson's is usually triggered by either a medication or an infection. And this reaction can start while you first started using it up to 2 weeks after you stopped using it. So just a little side note on that. So that is the big SNRI I want you to remember. And then we switch over to our atypical antidepressants. And probably the only one that I've seen prescribed with any sort of frequency is trazodone. Trazodone can affect one or two of the three neurotransmitters in the brain. So serotonin, norepinephrine, and dopamine. We cannot take an atypical antidepressant within 14 days of taking an MAOI. Trazodone, I'll see that as like a sleep aid sometimes. So it's not used as an antidepressant, but it does have antidepressant qualities. Which brings us to MAOIs. These ones have a ton of nursing considerations, and they're just not used very frequently because there are so many food restrictions. So MAOIs work on norepinephrine, dopamine, epinephrine, and serotonin. We use it if other antidepressants just haven't been effective at controlling the depression. Drug interactions. Vasoconstrictions and cold meds like your Sudafed that contain pseudoephedrine, that can cause a hypertensive crisis if taken with an MAOI. So I would advise my patient not to take any cold medicines with an MAOI just to avoid the potential of that. There's also food interactions. So they have to avoid foods that contain tyramine. And if you look at this slide, look at the stuff that contains tyramine. Cheeses, cream, yogurt, coffee, chocolate, banana, raisins, sausage, pickled foods. I mean, the list is really pretty extensive. And so that's a big part as to why they're not prescribed very much anymore. And then we've got some side effects, adverse effects to take into consideration. These are notorious for those orthostatic hypotension, anticholinergic, and then remember that tyramine interaction can trigger a hypertensive crisis. So these last few slides here on antidepressants, I focus in on the nursing interventions. So what are we going to do with a patient on an antidepressant? We're going to monitor their vital signs. We're going to monitor their mood for drug effectiveness. Is this treating the symptoms they have of depression? We're also going to make sure we monitor for suicidal tendencies because some of these drugs can trigger suicidal ideation. And then some of these drugs, people are at risk for suicide, and then we start them on these meds, and prior to taking the meds, they were so exhausted from their depression and they had no energy, and we give them these meds and suddenly they have an increase in energy, and so they suddenly have the energy to commit suicide. So we want to make sure we do that assessment. We also want to monitor for seizures. We want to warn for foods that contain tyramine with MAOIs. We want to encourage people to take the drug as prescribed, avoid alcohol, avoid other central nervous system depressants, avoid cold medicines if at all possible, or if you have to take it, consult with your physician or pharmacist. Take your medicine with food if you have GI distress. We're going to warn patients against driving or using dangerous equipment until they know how this drug affects them. We're going to tell them not to abruptly stop taking this medication. Generally speaking, we take it at bedtime, except for those SSRIs, which can cause insomnia. We want that taken in the morning. Usually it takes 2 to 4 weeks for patients to achieve a therapeutic response to really feel better. And I would just caution them to avoid herbal medications, especially ginseng, St. John's wort, because they're going to interact with their antidepressants. Okay, that wraps up depression. So let's touch base on mood stabilizers. So, mood stabilizers treat bipolar disorders, and that is depression and mania or hypomania. With both a manic or a hypomanic episode, you're going to have 3 or more of these symptoms. They're going to be abnormally upbeat, jumpy, or wired. They're going to show increased activity, energy, or agitation. They're going to have an exaggerated sense of well-being and self-confidence, a decreased need for sleep, unusual talkativeness. They could experience racing thoughts, distractibility, or poor decision making. For example, going on buying sprees, taking sexual risks, that sort of thing. So you've got your depression symptoms, and then you've got your mania or hypomania symptoms. And the big mood stabilizer I want to touch base on is lithium. And let's talk lithium. Lithium is one of those drugs that has a narrow therapeutic range. So we have to do blood levels. Basically somewhere around 1, a little bit below, a little bit above is a therapeutic range. If you get above 1.5 to 2, those are toxic levels. And there are some interactions that we need to talk about. NSAIDs, other antidepressants, Haldol, theophylline, which we're going to talk about in the respiratory chapter. We want to avoid those interactions. And then we get to side effects, adverse effects. And side effects should diminish as time progresses and people develop a tolerance to lithium. So headache, drowsiness, dizziness, low blood pressure, restlessness, dry mouth. You can experience some metallic taste, some GI distress, that sort of thing. These should be fairly repetitive from what the other ones have been in the mental health units. Some nursing interventions for lithium. We want to monitor vital signs and sodium levels. We want to monitor for drug effectiveness. How are they doing with the symptoms they presented with? We want to monitor for suicidal ideation or tendency. We're going to monitor urine output and renal function tests. Encourage fluid intake. Take with food to decrease that GI irritation. Monitor those lithium levels and know what the toxic side effects are. Some other nursing interventions, we're going to teach the patient to wear a medical alert bracelet so people know that they're on lithium. You want them to take the drug as prescribed and keep any medical appointments. Caution against driving until they know how the drug affects them. It can take a couple of weeks for the drug effect to be really felt. Avoid caffeine, crash diets, NSAIDs, and diuretics. Fluid and sodium balance is really important when a patient is on lithium. And then we want these patients to not get pregnant because lithium is a teratogenic, meaning it will cause birth defects. It's harmful to the fetus. That brings us to the end of this unit, and I've got a nursing diagnosis for you that you might be feeling pertains to you at this time. And then, as usual, on this last slide, these are the specific drugs that you should know, and please make note of what I had told you about these medications. And this will help you prepare for exams. So thank you for listening, and please email me if you have any questions.